So this was the last case we did that we finished on before. And what we can see here, if you remember, this is an arthrogram injection, and we see contrast extending into a partial tear of the supraspinatus tendon. The question is, which tendon is it? If we get multiple cuts, we can see the tear extending to the joint side surface, but extending interstitially longitudinally within the tendon. And here we're getting more posterior. And here, if we follow, we're really getting into the infraspinatus tendon there, and we can actually see the contrast extending longitudinally into the infraspinatus tendon. So if we look at it on the sagittal images, if you remember, this is the anteriorly, so this is the anterior insertion of the supraspinatus tendon. This is really the area where the fibers between the infraspinatus and supraspinatus interdigitate, and there's infraspinatus and teres minor back here. And so what we saw there really is this tear, though it looks like it's in the supraspinatus, is actually in the area of the overlap between supra and infraspinatus, and we actually follow the contrast. Whoops, wrong direction. We follow the contrast. It actually extends posteriorly, so it's primarily within the infraspinatus tendon, even though it can extend fairly anteriorly because of the way the fibers interdigitate. Okay, let's see. Jonah, what do you think of this case?
Okay, so we've got a couple fluid-sensitive coronal images here. We're seeing a signal abnormality along the distal aspect of the supraspinatus, a little bit of fraying along the inferior surface.
Right through here, right?
And actually, I'm afraid I'm not seeing your arrow, but yeah, that's the area I'm talking about. I see the rectangle.
So you don't see my arrow either? I wonder why that site... weird. Okay, so here's the T2 weighted image. What do you see with it?
Okay, well, you know, we're seeing some kind of little hypo-intense signal in that same area.
The T2, it really looks pretty dark.
Yeah, it looks pretty good on the T2. It's,
yeah.
You know.
So this really looks like an inferior partial tear with what really looks like maybe some fluid or contrast from the joint space extending into an inferior partial tear, but we really don't see much on the T2 weighted image itself. Now, if we go, this is now a year later, what do you see here?
Okay, well, we're starting to get some signal abnormality on the T2 there on the left,
So
and
you
know,
we're seeing a little signal. Yeah, and then on the right, we can see a little fluid collecting there as well.
Yeah, a little pocket there.
Mm-hmm. Okay. So again, this is a joint side surface partial tear at the insertion, and it's funny because a number of years ago, say, let me see how I've got to date myself now, but back in the late 1980s and early 1990s, so that's further. I was going to say 5 to 10 years ago, but that's more than that. It was actually believed that most tears start on the bursal side surface due to impingement. That was Neer's theory, who was an orthopedic surgeon in New York City. Well, we now find out that the vast majority actually start on the joint side surface rather than on the superficial surface, and only rarely on the superficial surface where we see high anatomic risk for impingement. So this is a more typical. There are a lot of different names for this. I like to just describe it as a partial tear of the joint side surface insertional fibers of whichever tendon it is. So it's really primarily the footplate. Okay, Dan, what do you think of this case?
We had a 27-year-old female with softball injury. We have a chrono, looks like a T1 fat sat arthrogram, I guess. Yeah. We have abnormal mirror signal of the superior humeral head near the supraspinatus insertion. So, but the glenoid looks normal, and there is a little tiny footprint, like articular surface, partial thickness tear of the supraspinatus with some tendinosis. So this all could be a little tear with tendon retraction, which they coexist, versus it could be some coexistent trabecular injury or contusion.
Okay. So this is pretty common. There are 3 causes. This is a little bit more anterior than typically, but these these signal abnormalities typically are more prominent posteriorly than they are in the mid portion of the head. They typically are primarily at the insertion of the infraspinatus tendon. There are three primary causes of that. I think we've talked about this before. By far the most common are traction injuries, really of the infraspinatus, supraspinatus, insertional fibers in that location. That's a very strong insertion, and therefore the bone can be the weaker link, and erosions in this locations are the rule rather than the exception in anyone over the age of 35. So that's very common. You've all seen that. This is also the area, a little bit posterior to this, is also the area where you get Hill-Sachs impaction injuries. And Deshali, what's the third thing? I think we've talked about it before. Yeah, that's also where you can get posterior impingement in the overhead athletes. So here we can see the footplate injury. And then here, this is actually contrast extending into the tendon itself. And it's really, this is indistinct. The inferior surface is still intact. So this is not a tear. This is just tendinosis of the tendon itself. Now, Deshali, what do you think of this case?
A 15-year-old wrestler with shoulder pain, coronal and sagittal PD images of the shoulder with fat suppression, or this could be a T1 fat sat after an intra-articular injection of contrast. And so it's a far sagittal image that we see, and there's a little bit of increased signal intensity anteriorly, posteriorly, where which may be within the infraspinatus. So then on the coronal, there's a high signal intensity there as well. So it's not as bright as the contrast itself. So maybe some partial thickness tearing, and there's a little bit of edema within the greater tuberosity as well.
So we can see, so this is a partial avulsion of the footplate insertion of the supraspinatus tendon in this location here. And this, in these young individuals, these kind of avulsions in this location these will heal actually quite rapidly. They have very good healing ability. If not, then this, as you can see, can extend, and you can get an avulsion of the tendon off of its bony attachment. So I think these are important, and when you see these, and these are typically only seen in young people and older individuals, the weak point is not at the bone-tendon interface. It's really in the tendon itself, but in young people, the tendon is really strong. I think these are important to call the referring physician on these, because I think that these are important, and the treatment really is one of rest. John, do you have any comments on this?
Well, that looks like an avulsion of bone, as much as I don't think that's a tendon, is it, John?
Well, usually these are really at the bone-tendon interface, so it's really kind of in the superficial bone, but it's getting both the bone and the tendon histologically. That's the weak point in these young kids.
Yeah, it's the calcific area of the insertion.
Yes. The calcified layer.
I don't think you would do anything for this. You certainly would just put a sling on the weight.
Okay.
I don't think that you would operate on this.
Okay. Yeah. You're the surgeon. Okay. Let's see. Did Jeff join us?
Yes.
Oh, hi, Jeff. Why don't you take this case?
Sure. Question of a supraspinatus tear, T1, coronal T1, PD fat sat, T2 images, and I'm looking at the fat sat PD, and they see what appears to be some mildly increased signal at the articular side of the supraspinatus tendon at the foot print. Looks like in T2 it is hyperintense, and it looks like it's an articular-sided partial tear of the supraspinatus at the footprint based on T2. It doesn't seem to go all the way to the dorsal side.
Okay, well,
yes.
Notice here's the musculotendinous junction, and as we talked about before, it should be right around the 12 o'clock position, so it's retracted about 1 centimeter to 1.5 centimeters, which is about the distance between here and here. So I think this is a complete full-thickness tendon tear with with retraction.
Okay.
And but this was normal at surgery. But I think is what happens here, and we've seen a couple of these over time. This is really a near full thickness tear, but it's primarily the bursal side, and there still is a little bit of intact joint side surface fibers here. But mechanically, I think this is a full thickness tear. And we've seen only some of these, but if you don't see, well, in this particular case, I would still just call this a complete tear. But sometimes, if you have fluid in the joint space like an arthrogram, you can occasionally see that the bulk of the tendon is torn and retracted, but you can have a sliver of inferior surface still intact if you have contrast between the bone and the inferior surface. In situations like that, I'd be sure and describe this as a near full thickness tear with just the deep fibers intact, because I think these need to be treated as full thickness tears, even though you can sometimes not see these arthroscopically because a superficial layer of the deep fibers can still be intact. So I think we can be very helpful to the surgeon on these cases if we describe accurately what we see. But here you can see both retraction of the musculotendinous junction and a defect in at least 90% of the thickness of the tendon.
I think the surgeon missed a boat on this one, John.
Well,
I'm not joking. I'm serious.
Well, it was someone I worked a lot with, and
well, I know, but everybody can make a boo-boo.
Okay. All right.
I mean, one or two mistakes in my life too.
I can't believe that.
And I'm perfect.
All right. Okay. Now, so let's go on to full thickness tears. So those are various types of partial thickness tears. There are a number of things that we can look for in looking for full thickness tears. We can see if there's fluid that goes into the subacromial bursa. We look for fluid in the subcoracoid bursa, which most of the time communicates with the subacromial bursa and not the joint space, unless there's a tear. If we see fluid interrupting the tendon, if we see proximal retraction of the musculotendinous junction, these are two things we just saw in that last case. Now, the other thing that be concerned about, you can have a full thickness tear if it's chronic and it pulls away. You can have scarring in the area of the tendon, and you can actually get scar in-situ, which can be dark on an MR sequence. And I'll show you examples of that. And those typically are symptomatic, and they typically need to be treated by resection of the scar and repair of the tendon tear. Then also with full thickness tears that are chronic, you get muscle atrophy. And muscle atrophy tends to be irreversible. And a lot of muscle atrophy is sometimes considered a contraindication to surgery, but we'll talk about that in a little bit. And then you can look for rotator cuff arthropathy. So these are the kinds of things we look for. Dan, what do you think of this case?
John?
Yes, John.
Not infrequently, you get considerable amount of bleeding when doing shoulder surgery. But what I'd like to know is how long ago was this done, that last case?
This case?
Yes.
I don't remember. I'd guess that it was 10 years ago.
It's probably longer than that, I would think, because, you know, as time progressed, shoulder surgeons got better. And I would think that it's just hard for me to believe that this surgeon was, I think I know who you're talking about, and we won't mention any names, but I think that somehow this was not appreciated by the surgeon.
Maybe you're right. He was one of your colleagues, but okay.
I think I know, but I'm not bad-mouthing the guy. I'm just saying that everybody can miss the boat sometimes.
But I really do believe that there can be situations like this where that either it's scar in situ or the synovial covering there can still be intact, making it not possible to see the defect in the tendon arthroscopically. Obviously, torn much farther back, you can't keep the synovial intact. But
Right.
it is a phenomenon that does occur, and I've seen enough examples where I believe that it can be, and therefore looking at the integrity of that inferior surface, which is better seen on an arthrogram, is something that's important to look at for the radiologist.
Yeah, all kinds of things happen in surgery, and so surgery is not perfect. I would say that in shoulder surgery, you probably have depending on who's doing it, probably 85%, 90% accuracy, but
Okay.
I don't think I can go past that.
Okay.
Anyway, I just wanted to
Thanks, John.
thank you.
Got a 45-year-old male with shoulder pain. We have a chrono, looks like a PD and maybe a T2 on the right.
T1.
T2. Okay. So looks like there's a gap of the, I believe that's the supraspinatus tendon. It's like almost like high grade or near full thickness tear with tendon retraction proximally, and there's a lot of like subacromial subdeltoid fluid with synovial thickening. So this is probably like a mechanical full traction. I mean full thickness.
So here's the sagittal, and again we can see a lot of thickening here, the synovium. This is really a full thickness defect in the tendon. The musculotendinous junction's way back here, so this is really a full thickness tear. So the only question here would be, how this is probably scar tissue that's developed in there, but in this particular case, I think it's this is a complete tear, and it's just with some scar tissue there. Areas of low signal like this within the bursa, it can be seen when you have relatively acute hemorrhage. So this might be a recent trauma on top of chronic disease, which has produced more recent hemorrhage. And here we can see a lot of the fluid in the subacromial subdeltoid bursa here with a lot of synovial thickening. So this is probably an acute on top of a more long-term chronic full thickness tear with retraction of the supraspinatus tendon.
In the shoulder, you cannot separate the synovial membrane from the capsule, and that's the two kind of go together. And the capsule, as you know, is very thin.
Yeah.
So a scar will form when you get tears in these areas.
Okay. And you can see there's chronic disease here with the osteophyte formation and hibernation of the acromion process there.
So we have two sagittal MR images of the shoulder with T2 weighted imaging, and there's fluid in the subcoracoid bursa. And on the first image, there's a maybe few millimeter full thickness tear from what we can see, I suppose, of the infraspinatus. Is that I'm sorry, anterior. So supraspinatus.
So that's very good, great. So sometimes these small anterior, this is probably the most common tear, are right at the anterior insertion of the supraspinatus tendon. And when you see fluid in the subcoracoid bursa here, then that's really not normal. That's almost always due to having joint fluid going through a tear into the subacromial subdeltoid bursa, which then drains dependently in the subcoracoid bursa. So seeing this, then you really have to look very carefully for the tear, and the tear is almost always there when you see it. And sometimes the subcoracoid fluid is more obvious than the small tear that may be leading to it. So it's this is a low field scanner, which we can see, but that's a full thickness supraspinatus tendon tear, and sometimes these fluid collections can be very helpful to improve your sensitivity. And this just kind of shows some of the anatomy here. This is the subscapularis muscle. Here is the capsule. This is the subscapularis bursa. This is joint fluid here. The fluid outside the capsule is not fluid in the joint space. This is the subcoracoid bursa, which generally communicates with the subacromial subdeltoid bursa. So here we can clearly see those two different potential spaces, and the significance of the fluid is very different in those two. Once you see it outside the capsule, if the patient hasn't been stuck by a needle or anything, then most of the time you're going to be talking about a full thickness rotator cuff tear, and you just have to then find it. Okay. Say, Jeff, what do you, wait, I think we skipped Jonah, didn't we? Jonah, what do you think of this case?
Sure. So we've got T1 and EDFS coronal images through the shoulder. We're seeing a lot of signal abnormality through the expected distal course of supraspinatus, and kind of some intermediate signal too, more proximally. And we've got a little bit of fluid kind of coming inferiorly as well. So, of course, we're concerned that this is going to be another supraspinatus tear.
So here's the sagittal, there's the acromion process, there's the supraspinatus. But as you pointed out, we have a little fluid in the subcoracoid bursa here. And this, well, so this really looks like to be concerned about an anterior distal tear of the supraspinatus tendon. The musculotendinous junction's in a pretty good position. This is suspicious for subcoracoid fluid. When we go to the sagittal, we see the subcoracoid fluid. On this particular sagittal image, there's a suspicion of some tendinopathy here, but not really a tear. But we go one cut farther out to the actual footplate insertion, and there we can see that anterior edge tear, and this is where the fluid is going from the joint space into the subcoracoid bursa, which is then ending up, in the subacromial bursa, which ends up in the subcoracoid bursa. So again, that's a very small tear, and you can actually follow the fluid out, if you carefully, coming all the way down into the subcoracoid bursa. So this was another tear of the anterior insertion of the supraspinatus. Okay, Jeff, what do you think of this case?
All right. So it looks like we have fat suppressed T1 after intra-articular injection of contrast. And
well, there's an injection of contrast. We might argue where it was injected.
Oh, well, yes. Okay, so after an attempt to inject into the joint space, looks like there's preferential contrast. So on this, looks like there's preferential contrast in the subacromial space and in the subcoracoid space there.
Going into the subcoracoid, that's right. And you can see there's previous surgery here with metal artifact and greater tuberosity. And here we can see the extravasation of contrast out here peripherally. And this was actually a subcoracoid injection of contrast. So, let's see. Dan, what do you think of this case?
The answer to the top.
Actually, let me do this. Okay, after surgery, here we can see that there's surgery here. And here we can also see there are other reasons for having subcoracoid fluid, though by far the most common without surgery is going to be a rotator cuff tear. But here we can see there. Now here's another case where we can see a full thickness tear of the supraspinatus tendon, not much retraction of the musculotendinous junction, but we can see the fluid going through a small tear into the subacromial subdeltoid bursa. Complete full thickness but smaller tear. And here again we can see fluid extending through a tear into the subcoracoid joint space. Now, and here again see another full thickness tear with fluid going through. So, okay. Dan, what do you think of this case?
It looks like we have a coronal, I believe it's a T1?
Yes.
T2 image. And yeah, so there's a little fluid in the subacromial subdeltoid bursa, and there's just a low signal intensity in the kind of, again, subacromial. I was worried about that's not a distal end of the tendon. That's just, or it's like a.
Yeah. So what's happening here is you've got a tear of the tendon,
right,
and it's frayed back again, and you have kind of an L shape to the tendon. What you're catching here is partial volume of the displaced tendon.
Okay.
So that's exactly what it is.
Okay.
Here's that's where the tendon should be attaching to the bone in case the anterior edge is torn, frayed back, and it looked like it was a loose body. That's what people thought this was, but it's not a loose body. This is just catching the end of the tendon, which happens to be low signal intensity on our pulse sequences, and that's where that tendon should have been inserting into the bone there. So that's another supraspinatus tendon tear. Here you can see an arthrogram with a full thickness tear with free communication. And here we can just see this is all pretty straightforward. Here's another tendon with an avulsive erosion there. The tendon's retracted back here. So what is all this low signal intensity structure? If this is a complete tendon rupture, then why don't we have a lot of high signal intensity here?
So
It's all nice and dark.
there's also dark signal within the rest of the joint space too. So this could potentially have been a patient who had, they did an arthrogram and it could have been abnormal concentration of the gadolinium.
If it's too strong,
Yep.
that's not the case here. This isn't.
So otherwise it could just be scarring, or it could be amyloid, dark signal.
Right. Amyloid, we'd expect more
Erosions.
diffuse, thickening of the capsule and amyloid deposits really out around it. In this particular case, this is a full thickness tear with retraction. We see the musculotendinous junction should be up here. It's retracted way back here. This is the distal end of the tendon. That should be attached to the bone here. All of this dark structure here that looks like tendon is all scar in-situ. And it can be very misleading. Here's a sagittal image. This looks like completely normal tendon on the sagittal image with just a geode in the bone. But this is all thick scar tissue, and the scar tissue is very friable. It's mechanically not strong, and when you tug on this, there are nerve fibers in this, and it can be very painful to tug on this because it doesn't have the mechanical integrity of tendon, so it can be very symptomatic. Here's another case where we see the musculotendinous junctions way back here, distal end of the tendon somewhere in here, and this is all scar in situ, and we can see fluid going through the defect here. And just another example of more examples of scar in situ, complete tendon tears, proximal retraction, and this development of scar in situ that you just need to be aware of. That's actually the distal end of the tendon, and this is all scarring in through here. Okay. Now, the other thing that you look for, which is actually quite uncommon, but important to recognize, let's see, Jonah, what do you think of this case?
Sure. So we've got a couple coronal images, T2 probably, and PDFS. So we've got a very high position of the humeral head, and it looks like a full thickness tear of supraspinatus. Now we see this hypo-intense structure kind of drooping into the glenohumeral joint space, and I'd be concerned that that's actually just the supraspinatus tendon kind of flipped down there.
Which is what it is. So as you said, this is a complete full thickness tear. It's relatively chronic. We have superior migration of the humeral head with direct bone-on-bone articulation, but the thing here is the supraspinatus tendon actually has subluxed into the glenohumeral joint space between the glenoid and humeral head. So this is fairly uncommon, but tends to be associated with symptoms. And we can also see a lot of bone marrow edema here from chronic trauma from the bone-on-bone articulation. Okay, Jeff, what do you think of this case?
66-year-old female, failed 10 days ago, can move her arm. And we have multiple coronal, well, I think they're coronal. It looks like coronal T2 or PDFATSAT. Yeah. PDFATSAT images. So it looks like we have a, I mean, there's essentially very high signal in the area would expect the supraspinatus tendon. I think that the musculotendinous junction is basically retracted. So I think we have a full thickness tear, supraspinatus tendon with retraction. And I think what I'm also seeing is a significant, extensive synovitis, within the glenohumeral joint as well, extending into the subacromial bursa. And I think we're far. I mean, we're on this coronal. We're probably far anterior on those two images there. But let's see what else. Okay, more coronal images. So again, it looks like severe synovitis, and Oh, it looks like, oh. So on this image here, the axe image, we have it looks like anterior subluxation of the humeral head, and I don't see the biceps tendon within the bicipital groove.
So what we have here, okay, so we have tears of the supraspinatus tendon, where the tendon has moved into the glenohumeral joint space, like on the last case. In this case, however, we also, if we look at this on the axial images, we have a tear of the long head of the biceps tendon, and also the subscapularis tendon is torn, and it's also subluxed into the glenohumeral joint space. So there's a good reason why this patient couldn't move their shoulder.
Wow.
So the tendons had displaced in the joint space. This is not common, but be aware of it. It's important to describe it, and this is another case where you need to get on the phone and talk to the referring physician if you see it.
I suspect that this patient also had a dislocation like the other one.
I agree with you. Yes, this patient had a dislocation. And probably and obviously it's going to be a very unstable glenohumeral joint at this point. Okay. Let's see. Dan, are you next?
Yep. So we have a single fluoro image from arthrogram injection of the left glenohumeral joint, which shows the contrast is within the joint, but it also extends to the subacromial bursa. There's a little like sliver of contrast going up, and so if this patient has not ever had a surgery, then this indicates that there is at least a pinhole or some full thickness tear for communication.
Get an MR scan because of the pacemaker.
Oh yeah.
And there's the fluid going into the joint space. And here on the CT, we can see there's free communication between the glenohumeral joint and the subacromial subdeltoid bursa, consistent with a rotator cuff tear. But the detail really isn't nearly as pristine as we have on the MR examination. So if you don't have a pacemaker or some other contraindication to MR, we still prefer to evaluate these with MR. Okay, Deshani, this patient came in with shoulder pain.
So we have two coronal images, T1 and T2, PD fat set. So there's a lot of edema in the greater tuberosity, and there's low signal intensity at the insertion of the supraspinatus on both sequences. Okay.
I think within this cell at Vail quite a few years ago skiing, and this was his skiing injury. Okay, and so then we've seen a lot of kind of unusual type tears. So what do you need to have in your report when you dictate a report? And this comes from David Stoller's course back in August of 2003, where Richard Hawkins, who was then at the Stedman Hawkins Clinic in Vail, gave a talk as to what he wants to see in the radiologist report. So we talked earlier about the size of the tear, the quality of the tissues around it, the exact location of the tear, and another thing he wanted to see was whether or not there's fatty infiltration into the adjacent muscles. So looking at the muscles then, and describing what you find on the muscles, there are a number of things. You need to describe the volume. I like the sagittal scans, but there are some potential problems with the sagittal scans. And there's a thing called the tangent sign, and then also increased fat within the muscle. These are all things which make surgery less likely to be successful. So the tangent sign was first published in Radiographics in 2006. It uses the sagittal plane, usually a more medial part of the sagittal plane. Excuse me. So here's the sagittal plane. Here's the scapula here. Here's the acromion process posteriorly, the distal clavicle here. So this is the Y of the scapula. And the supraspinatus muscle is the muscle above it, as you know. The infraspinatus and teres minor are back here. The subscapularis is down here. And if you draw a line between the superior margin near the coracoid process and the superior cortex at the acromion here at the top of the Y, the supraspinatus muscle should extend above this line. If it doesn't, that's abnormal, but there's a problem with this. So this would be abnormal. The dark, this is a fat saturated image, so this would be fat up here, and here we can see the supraspinatus muscle does not extend above that line, so this would be abnormal. Which we can see. And the problem with using this is that should need a coronal image. Should have the supraspinatus muscle is a cone-shaped muscle, and it comes down almost to a point where the tendon takes off. Then the supraspinatus tendon goes over the humeral head and attaches to the greater tuberosity. If you have a tear, a complete tear of the supraspinatus tendon, then the muscle will retract medially, and since it's a cone-shaped, it can retract medially and have a positive tangent sign, even though it could be acute with no atrophy at all. That's why I don't like this. If you have a complete tear, this happens to be a big-time athlete here. You can see the size of his muscles. An acute tear, if it proximally retracts acutely, you can have a positive tangent sign but no muscle atrophy. So you have to be careful of that. So you have to look on the coronal images and make sure that you don't have immediately displaced tear, which could make this a false positive sign. So I don't really like to use this sign, but if you use it, it's okay as long as you make sure that this is not due to medial displacement of the muscle itself. So here we can see this is kind of that Y-shape, and if we draw a line between the superior cortex of the acromion and the superior part of the coracoid process here, this would be a positive tangent sign because the supraspinatus muscle, the top of it, would come underneath that particular line. In this case, we can also see there's a lot of injury to the infraspinatus and probably the subscapularis tendon. It looks like there's a lot of injury here. If we go to the oblique coronal images, what we can see here is, here's the musculotendinous junction, here's a complete tear of the supraspinatus tendon, and there's medial retraction. Notice if we look at the muscle, there is no fatty atrophy in this muscle at all. This is one that just medially retracted, so this is a positive tangent sign, but there is no atrophy of the muscle here. So this is a person who would actually be a great candidate for surgery, and the tangent sign could be misinterpreted as saying he's not a surgical candidate. So instead of actually looking at the tangent sign, I think a better sign is to look at the amount of fat within the muscle itself. And we'll talk about grading the amount of fat in the muscle in just a minute. So this is one that does not have atrophy. So make it short. I don't like to use the tangent sign. So here's a 77-year-old female with acute injury and shoulder pain. Again, a positive tangent sign. The supraspinatus muscle is below the tangent line. See a lot of fat above it here. And if we go to the coronal images, again, we can see a complete tear, proximal retraction. The muscle does not have fat in it. So this is another case where we have a positive tangent sign, but there's no atrophy in the muscle itself. Okay, so this is published by Mulatto and AJR in 2005, where you actually grade the amount of fat within the muscle. Stage 0 would be no fat. A few fatty streaks for stage 1. If you have more muscle than fat, that would be 2. If you have equal amounts of muscle and fat, that's a 3. If you have more fat than muscle, that's a 4. And according to their work, stage 3 and 4 are poor surgical candidates, whereas stage 0 and 2 are still good surgical candidates. So instead of using the tangent sign, I like to look at the muscle itself, and as long as you have more muscle in the volume than you have fat, the patient still is a good surgical candidate. So here's an example. Here we can see there's a complete tear of the supraspinatus tendon, proximal retraction of the distal end of the tendon and the musculotendinous junction, and here we can see a lot of streaks of fat within the muscle, but there's still more muscle than there is fat. So this would be a stage 2, and this patient would still be a reasonable surgical candidate if everything else were fine. Okay. Here we have another example, someone who's post-operative. There's been a post-op tear of the supraspinatus tendon with retraction, and here we see that there's a lot of fatty atrophy, especially inferiorly. This would be equal amounts, stage 3, and this patient would then be a less optimal candidate for surgery based upon atrophy. And the reason why it's considered to be a poor risk for surgery is that once you get a lot of fat within the muscle and fatty atrophy, along with this fat is you have fibrous tissue, and the muscle itself becomes very stiff, and if you try to stretch it back over to repair the tendon, there's too much tension in that, and the surgical site will break down. There are other techniques where you can put other tissues. Instead of bringing the tendon all the way over, you can put in grafts here to try to repair it without bringing the tendon all the way over. But those, I think, are still mostly experimental. Yeah, yeah. Some of them out here that people use are called graft jackets, and there are several different versions of it. But if this person's going to surgery, then that's kind of the surgical procedure that you'd be thinking about. Okay. See.
They may help with pain if you put a filler in there, but function-wise, they're not much.
They don't have
much help. There are tendinous transpositions that you can use, but that's not in these age groups. So it's only in younger people. So there's a lot of mouse traps in the shoulder, like at many other places of the body. But your tissue is what you've got, and many times new mouse traps don't do the job.
Okay. I never thought about putting a mouse trap in the shoulder, John.
Well, it depends on what kind of mouse trap.
Okay. Okay. Who's next? I forgot where we were. You? Okay, Shally.
Okay, so 75-year-old male, single suture ankle repair 3 years ago, which was placed at the base of the greater tuberosity because the tendon could not be stretched. So we have two coronal images, a coronal T1 and PD fat set, and there's metal artifact from two anchors. One's in the bone and one is not in the bone. The superior one, it's retracted into the soft tissues proximally with the supraspinatus. So it's been pulled out.
What happened is that they actually put the suture anchor instead of over here. They actually put the suture anchor in here, and part of the actual articulating portion of the humeral head. And despite that, it still pulled out, and it failed. So, all right. Jonah, what do you think of this case?
Okay, so we've got a coronal image here. We're seeing quite a bit of fatty atrophy. I guess probably stage 4 of
4 to 4
over there.
And you can see tendon, bone on bone, some osteophyte formation here. So this is really a stage 4, not a good surgical candidate.
Sure.
And then here we can see this is the infraspinatus, where we can, teres minor, we can see marked fatty atrophy here, also of the deltoid, stage 4. And in this particular case, this was due to cervical neuropathy. So, and this is much more extensive than we would expect if we were just talking about tears, because it's actually involving more muscle than just the rotator cuff here. So when you see that, you have to think about other possibilities. In this case, it's a neuropathy from impingement of the cervical spine. See, the next thing that he wanted described in the report is elevation of the humeral head. We've seen that on a number of cases. Here we can see that the humeral head is markedly elevated with the direct bone-on-bone articulation with the acromion, which is also abnormal here with a lot of eburnation. Here we can see the supraspinatus tendon is torn and retracted. And you can see how unstable this joint space is with the humeral head really well out of position with respect to the glenoid. And so he really would like this described. and give an estimate of how much superior migration there is, the fact that you have bone-on-bone articulation, and there's actually been remodeling of the acromion process. And here's just another case where we can see superior migration of the humeral head, tear of the supraspinatus, probably stage 4 fatty atrophy of the supraspinatus. This is on 11/17/07. Here we can see on the sagittal images marked atrophy of the muscles. And here we can see wait, let me see, yeah. And here's a double row technique to attempt a repair. And we can see that even after the repair, the tendon's been torn and retracted again. So that wasn't successful, even though they tried a double row repair. This patient had a number of negative factors, and it was not a successful surgery. And we can also see a lot of deltoid disease here as well. Yeah, and rotator cuff repair, we'll hear a lot more about these, or you guys will hear more about this in later talks at Curl and Job when we get to the surgical discussions of how to do this. Basically, you just put in a suture anchor, you put the sutures up and bring the tendon back over and tie it down. There are a number of different hardwares that can be used, a number of different techniques. And we'll be talking about single row, double row, and so forth, and talks later on. But that's basically what we'll be talking about. So here's a case where we have pre-op, and we can see a tear with fluid going into the subacromial subdeltoid bursa. We only see part of it on this one image. If you saw the other image, you could see a typical tear. After surgery, in this particular case, what happens is they bring the tendon down, and we can see that the fluid which was within the tendon is no longer there. We can see scarring and thickening here in this area, and this was pre-op, where we can see the area of the tear. Here's where the suture anchor was. They brought the tendon back down. It scarred in and healed, and we can see the post-operative result. And the patient improved clinically there. And there are a lot of different kind of suture anchors. We were talking about that before. Some metal, which are less expensive, some which are resorbable, which tend to be more expensive. So there's often a fight, as with the insurance company, as to which kind you can use. Now, a technique that has become popular to try to increase a couple of things is the double row technique. One is if you put in, and this is typically 4 suture anchors, 2 proximally and 2 distally. And there are a number of reasons to do this. One is if you have 2 suture rows, you've got 2 sutures to connect to the tendon to hold it. But one of the important reasons, and the technique is important here, is that if you just do a single row technique, if you get bone to tendon healing, you tend to get healing, but it's much smaller surface area of contact to the bone than in the native foot plate. One of the reasons to use a double row technique is if you do it properly and you get uniform pressure of the tendon against the bone tendon interface can be as large as the native bone tendon interface, which then gives you more likely for long-term success. So there are several reasons why people like this technique. However, in the literature, there have been a number of studies looking at whether this is more successful than a single row, and at least stuff that I've read shows that there's not a clear advantage of the double row technique, though we published a paper where we thought that there was an advantage and long-term success using a double row technique.
Did he scrape the bone before they put the anchors in? So
All right. And the most important thing when you do this kind of a procedure is the raw bone that you create at the footplate.
Okay.
And more medial if you need to. Whether you use 2 anchors or 3 or 4 is not as relevant as having the sutures tied to good tendon, not a frayed tendon. So from what I read in the literature, double row is not of any better result producing than a single row. The main thing is you have to tie the sutures down. You shouldn't be really tight, and there shouldn't be too much pull on the tendons. And of course, post-operatively, immobilization, I think, is important. Some people try to immobilize, try to move the shoulder too fast, too early in time. I think you should immobilize for at least a couple of days so the muscles are not in spasm. But anyway, I know that Colonel Job likes this technique. It's much more time-consuming, more expensive, and actually in literature, I'm not talking from my own opinion and my own experience, but the literature doesn't indicate any improvement in results.
Yeah.
So,
and there's debate about that. Some people believe that some of the techniques, when you do a double row technique, you don't get uniform pressure of the tendon and the bone between the two rows, and you tend to get buckling of the tendon here and not bone to tendon healing. Whereas if you use a technique where you have uniform pressure, you can then get healing all along the foot plate. And some people believe that may be the reason there's disagreements in the literature concerning the outcome of double row versus single row. But
right.
I still think it's controversial.
It is, and tying the sutures, you never get the same tightness one way or the other. And it depends on where you start, medially or distally, in terms of tying the sutures. The medial sutures are the ones that give you the main tension if you do a double row. But anyway, like I said, you need the raw bone, as much raw bone as possible, and good anchor fixation and good suture that will not cut through the tendon.
Great, thanks, John.
What I used to do is I used to use two drill holes and then make three sutures in a horizontal fashion out of two sutures, and I got not a double row, but I got three sutures going two ties to each other and crossing each other. So,
okay,
many ways to do it.
Yeah. Okay, and it just shows post-operative changes. One thing that I just want people to be aware of, after surgery, if you do an arthrogram, even if it's a completely successful surgery, you frequently will get leak of contrast from the joint space into the subacromial subdeltoid bursa. So the findings that we had in the native shoulder, whereas if you got contrast into the subacromial subdeltoid bursa, that means that you have a rotator cuff tear. That you can't use post-operatively because you can see this in a perfectly normal post-operative case. And this is an example where we don't see any breaks in the tendon, but we see fluid extending from the joint space into the subacromial subdeltoid bursa. So that sign is not reliable post-operatively. You actually have to see a defect in the actual tendon itself once you have surgery to make sure that you have a post-operative tear. The other thing that you can see in this particular case, we can see the suture anchors out here. We see the musculotendinous junction is a little bit proximally retracted, and a lot of irregularity of the tendon in through here. And here we can see the musculotendinous junction that looks like the distal end of the tendon, and this looks very irregular, typical of scar in-situ. Here's a case where we can actually see an obvious defect in the postoperative rotator cuff. And here's a suture anchor. There's the tendon. There's no tendon here. We can see the infraspinatus tendon back here. And so this is a retear after surgery in this particular case. And there's a defect. So And that just showed a case where you have a tear next to the surgery. Here's a case where we have postoperative changes with a clear retear of the tendon, large detail. Okay, and maybe this will be the last case. Who's next? Is it Jonah? Jonah, why don't you take this case?
Okay, so we've got a 35-year-old with shoulder pain. Got coronal images. It looks like we've got a repair anchor. Now, we do have another hypointense linear structure kind of drooping down into the glenohumeral joint space.
Yes, yeah. That's going to be the labrum there.
Yeah, good, good. Kind of some fluid throughout, which could be expected.
So you've got a little bit of fluid going into the tendon here. What's that?
Okay. So I guess we could have some fluid dissecting into the
tendon. So here's the construct. That's intact, and you can get tears adjacent to the construct. The last tear actually was a bigger tear adjacent to the construct. Here the construct is intact, but you have a partial tear of the tendon really adjacent to the actual repair side of the tendon itself, and this was symptomatic in this individual. Actually, no, let's do this be the last case. Jeff, what do you think of this case?
All right, 75-year-old male, shoulder pain, no symptoms of infection. So what we're seeing on this coronal, looks like a coronal T1, T2 images. I'm concerned about, so where we see the suture anchor in the humeral head, and I'm concerned about the hyperintense signal surrounding the suture anchor on the coronal T2 image there. It looks like I'm concerned about basically an erosion, maybe related to infection, or maybe related to loosening or of the anchor in the humeral head there. Yeah.
Yeah, and certainly if I just saw these images and I knew nothing else, I'd be very concerned about post-op infection with erosion of the bone in this location. Also notice the suture anchor is a little bit medial to the actual insertion plate. Here's a PD fat set showing all this bone marrow edema within it. What else could this be if it's not infection?
Okay, so it's not infection. Maybe it's related to some type of inflammation related to the resorbable form reaction. Yeah, inflammation reaction related to this.
In the past, some of the resorbable suture anchors, patient could actually get reactions to the suture anchor itself, and so this was actually a reaction to the to the suture anchor, and this was all inflammatory debris from a foreign body reaction.
John?
Yes?
The way this reads is a resorbable suture foreign body reaction. That indicates resorbable suture reaction, not anchor. I wonder if that's an error or...
That's my error. Thank you. I'll get that corrected.
Because there are sutures that do cause reactions, but...
Yeah, no, that's wrong. Thank you for... I'll get that corrected right away. That should be resorbable suture anchor reaction. Thank you.
Foreign body reaction.
Yeah, foreign body reaction to the resorbable suture anchor. And one nice thing about the metal anchors is that you don't get this. Thank you. All right, does anybody have any questions? Okay, we'll try to finish the... Yes?
You don't get this with metal anchors?
Yeah.
Metal anchors can cause
In the shoulder, I've never seen particle disease. If you have large chunks of metal like a hip prosthesis, in fact, I saw a really good example of particle disease earlier today from the hip.
Well, you're probably well with the reverse...
Oh, reverse prosthesis in the shoulder. But not from a metal suture anchor.
No, I don't. Well, you've seen a lot more of those in MR than I have, for sure, for sure.
Yeah, I've never heard of foreign body reaction from just a particle disease from just a suture anchor. It's usually a complete prosthesis. Okay, I'll see everybody tomorrow. Thanks.
Okay, thank you.
Yep.
Thanks.
Have a good one.
Thanks, John.
You have fun?
I did. It was great. Paris was wonderful. The weather was ideal.